Karthikeyan. I'm Professor of Cardiology at the All India Institute of Medical Sciences, and with me here is Professor Sripal, Bangalore, very well-known, multifaceted personality. So we can talk about many things today, but we've decided to just talk about a few of his more recent interests, and hopefully this will be of interest to everybody. So, morning, Sripal.
Thank you.
So first of all, I mean, just by the way, because people in India would like to know where you're from, so originally, so if you can tell us something.
Yeah, so originally, as my last name indicates, I'm from Bangalore. So grew up in Bangalore, did my medical school there, but I've been in the US, in New York, for 18 years now.
Okay, great. So that, we'll put that aside for the moment, and I thought we'll talk a little bit about ischemia now that enrollment is complete, and you will be presenting the results later next year, I suppose.
Right.
And also about ischemia CKD, which is part of your interests. And then we will talk about, because we've done quite a bit of the meta-analysis in various aspects of cardiology, we'll talk a little bit about one particular thing which I'm interested in, and then we talk in general about meta-analysis. Is that
Yeah,
okay?
that sounds great.
So, ischemia, can you tell us about the progress of ischemia right now, just because people are looking for the results of ischemia? So
Yeah, absolutely. So, so we have finished enrolling in ischemia trial. So we have randomized around 5,179 participants. The revised target was actually 5,000. So we are kind of pleased that we were able to get to 5,179. And I think that number is important to keep it in perspective, because if you look at Courage and Barry 2D combined together, it's around 4,500 patients. So now ischemia has enrolled more than Courage and Barry 2D, and we have enrolled a higher risk group of patients. So the follow-up will end in June, and we are hoping to present end of year next year. I mean, it's a tight timeline, so we are hoping that we can get our data in, lock it, and then present next year.
So what is your gut feeling about?
I wish I knew. So I think it will be an interesting results to see.
Most certainly, definitely. Yeah. So before we move on from ischemia, I just wanted to talk to you about the controversy about the changing endpoints that I think many people have misunderstood it a little bit. So maybe you can just take this opportunity to clarify it.
Yeah, I think part of the issue is, I mean, it was triggered by an editorial where they said shifting goalposts, etc. The sites which are actually involved and the team which was closely involved right from the design part of the trial will know that everything was pre-specified. Nothing was changed, and we had a plan when we went in. I mean, initially when the trial was approved by NHLBI, it was a 5-point composite endpoint. And we were like, we wanted to make it more stringent. We said, let's start with a 2-point. And during the conduct of the trial, if we find that we are underpowered, we'll have a special committee which will recommend what to do at that point. And that's exactly the procedure we followed, and the committee recommended switching back to the 5-point endpoint. So in other words, there is no non-pre-specified change in our endpoint. So everything was pre-specified.
And also the data is still blinded, right?
Exactly. It's all blinded.
So I think the main concern of the editorial is Daryl Francis and his group from Imperial. They probably, I think the issue was that they were looking at the 3 non-hard endpoints within the composite. So maybe you'd want to clarify how in the whole scheme of things, this is still going to be adequately powered for you to assess what you set out to assess.
Yeah, first of all, I want to emphasize that if you look at our endpoint of CV death and MI, it's still our major secondary endpoint. So if you go back to the primary endpoint, the 5 composite, we have a response. I mean, we published this viewpoint after Daryl Francis published theirs, and where we emphasize, like, look, I mean, all of these, true, there are softer endpoints, but we have very strict objective criteria. So, for example, the hospitalization for unstable angina, the criteria is very objective. I mean, you need EKG changes or angiographic evidence. So it's not like somebody walks in, complains of chest pain, they will be coded as hospitalization for unstable angina. The same applies for hospitalization for heart failure. So even though these are softer endpoints, our definitions are very stringent, and that's why we feel that. So at the end of the day, I know we in clinical trials categorize primary, secondary endpoint, but here I think the totality of data is important. We will present the 5-point composite. There is still the secondary 2-point, more robust endpoint, and people have to look at all the results and conclude themselves as to how best to take those results.
The non-fatal, say unstable anginas, non-fatal NST, ACS endpoints will not be like FAME2, for example. I mean, that was the main concern I think they raised. So it's more stringent than FAME2.
So it's absolutely more stringent, more objective, and given the fact that this is unblinded, I think this is very important, because if it is unblinded, you can imagine that a patient walks in, complains of chest pain, the sites know that.
Which happened in FAME2. So
exactly, which happened in FAME2. So this definition is much more stringent. I think that's important to emphasize.
Right. So moving on, let's talk about your part of the study, so the ischemia CKD. So can you tell us what you're really looking for and why there is a need to do a specific CKD trial?
Yeah, so if you look at the CKD population as such, I mean, it's a growing, complex group of patients with a high prevalence of coronary artery disease. And the problem in the past, I mean, if you look at COURAGE trial, there was no exclusion based on GFR. But if you let a trial run by itself, you'll see that physicians don't enroll these patients. They are very sick and they feel like, oh, we shouldn't enroll these patients. Patients themselves are not willing to be part of clinical trials. So that's one of the reasons we say, like, we need a dedicated trial. If we just said ischemia trial will enroll all ranges of GFR, I don't think we would have gotten to where we are right now. So that's one of the reasons we designed this parallel trial. And I'm pleased to also note that the trial has finished enrollment. We have randomized 777 patients, and that's the largest randomized trial for this advanced CKD cohort. The timelines are very similar. The last follow-up is June of 2019, and we are hoping to present later next year.
Great. Let's move on to your one of your main interests. I presume it's one of your main interests, which is doing meta-analysis of a lot of stuff. So one particular thing which I'm interested in is there have been, as far as I know, at least 5 or 6 meta-analyses on culprit only versus multi-vessel PCI for STEMI. I know that your one of the recent meta-analysis was looking at per procedure, during the first procedure, multi-vessel PCI versus staged versus compared to culprit only. Yeah. So, and you presented slightly different results than previous meta-analysis did. Do you want to elaborate on that a little bit?
Yeah, so what we did for this is to look at data to date. I would say whatever were the randomized trials which were published up until that day, and dividing trials into 3 different arms, where the first one was culprit only, which is easy. The second one was complete in 1 setting and complete in 2 settings. And we wanted to look at the difference in outcomes to try to figure out which is the best strategy based on data whenever we published this. This was like 6 months ago. Given that we have 3 different arms, so we did a couple of different strategies. One was to do a direct comparison, and one was also to do a network meta-analysis of comparing all of these 3 different groups, and to see, can we come up with, at the end of the day, can we say which is the best strategy for these patients? And interestingly, what we found was a single setting complete revascularization was associated with significant benefit. And of course, the benefit, all of us can say, if you completely revascularize, you'll have the benefit of less repeat revascularization. In the culprit only, you will have, the patients will come back, at least a small proportion will come back later on. But we also found that in the single setting complete revascularization, there was actually a benefit for reduction in death or MI. I mean, that being said, all of these confidence interval, point estimates are wide confidence interval, so we need more definitive trials. I mean, 2 such trials are in the works currently, and I think we'll gain more insight sometime next year about what strategy to follow. But I think this is one of the good example because if you remember 10 years ago it was class 3 to do complete revascularization at the same time of the culprit revascularization. Now 10 years later, multiple randomized trials, and now we are seeing a trend that maybe completely revascularizing may be a better option. So the guidelines now from class 3 is now to 2B and 2A and so forth. So I think this kind of emphasizes the value of randomized trials to one extent, but also meta-analysis of randomized trials to incorporate all of these data.
If I were to play the devil's advocate and tell you that you know that there have been trial sequential analysis for this particular subject, and people have said that there aren't sufficient data to arrive at some conclusion regarding at least the hard endpoints, death versus MI. So, how would you respond if I were to tell you that so many meta-analysis, and many of them have said they've sort of jumped the gun. So we're waiting for complete or one of those big trials, which will tell us more definitively. But before that, we've already jumped the gun. We've said, okay, this is the best way to do it. At least the meta-analysis seem to suggest, without being adequately powered. So
good point. I mean, in most of that's why even with this analysis, we emphasize that the confidence intervals are wide. But what we are seeing, we also published a trial sequential analysis, but despite all of this, the trend seems to be in the same direction. What we are seeing from all randomized trials so far is the culprit only seems to be the worst strategy, and the complete seems to do better. The question is, should we do complete at the same setting, or should we stage it? I think that's the question. And then the second question is, will it actually make a significant impact in reducing death? But what we are seeing so far, at least for many of the different endpoints, that culprit only seems not to be the best strategy. So I think it's some form of complete repass. But I also want to emphasize that we have to be aware of what kind of patients were enrolled in these trials, because these trials had a lot of exclusion criteria. Patients with CTOs were excluded. Any kind of left main disease were excluded. So I think we have to be careful in implementing this to clinical practice. But at least for 10 years ago, there was no randomized data. Everything was based on observational studies, and guidelines put in class 3 don't do this. Now, multiple randomized trials, none of them well powered until we get to complete and other trials. But at least the point seems to be that the guidelines are aligned with the data as of today.
One more little point that I find a little bit niggling is the fact that mortality, the mortality difference in all these meta-analyses is driven by one single trial.
Yeah.
It's the wall trial, right?
Right.
So, the moment we do a meta-analysis and present the same results, knowing very well that just one trial has influenced that so much, it kind of legitimizes or maybe makes it even more robust than it seems.
Right.
So I kind of think that, I know that you've said that as a limitation, but I think people should recognize that as an important
absolutely,
limitation.
absolutely. I think again, just like anything else, I would say it's the totality of data, and this is one of the things. I teach meta-analysis for a master level course. Meta-analysis, I don't think it adds anything more than what you have, right? So you have randomized trials, so it'll provide data from those randomized trials. It'll have the same strengths and limitations. And that has to be taken as one more evidence in the totality of data. And that evidence will change with accumulating evidence and so forth. So will it actually, do we have robust data to actually say complete revascularization will reduce mortality beyond any reasonable doubt? I don't think that's true. At least we're seeing a signal. And the signal is actually interesting because in clinical practice, I rather go by, okay, it's going to reduce other endpoints, maybe MI, surely repeat revascularization, and maybe potentially there is a mortality benefit. If the signal was in the opposite direction, then that would make me getting more concerned.
So in this context, this is one approach to do things. You do go at it from the data perspective, and the other approach is to look at it from a physiologic perspective. So I'd be interested in knowing what your thoughts are on, for example, that in the situation of shock, multivessel PCI has gone out, where we thought that it's probably more physiologically going to be more useful in terms of myocardial salvage or stuff like that. So I wonder what you think about that, because
absolutely. I think that this is the reason why we need to do randomized trials, right? Because everything is switched around. So many years ago, 8 years ago, we were planning on a randomized trial for STEMI, complete versus culprit. So I have more insights into this. The preliminary data did suggest that if you were to completely revascularize, there is faster recovery of LV function when compared to culprit only. And physiologically, it does make sense because if you have a patient with multivessel disease who comes in with a STEMI, it's not only the infarct-related territory which is affected. Of course, that wall is not moving. We really want in those situations for the rest of the walls to be hyperdynamic, not just contract normally. It should be hyperdynamic to compensate and make sure that the output is maintained. So if you have a critical lesion, it's going to impair that. And the physiological rationale for complete revascularization is, okay, so you're taking care of that, and hopefully, that's the reason that the risk of future deterioration or future events is minimized by completeness of revascularization. And that again goes back to why should there be a benefit of a single stage PCI versus single procedure at the time of culprit only versus staging it. And I think the reason is if you stage, it's likely that you may miss out on events. So if you stage it in a month time, patient may come back like 2 weeks later with an MI. So you may not provide the upfront benefit. So if you can complete it at the time, maybe it's beneficial. But of course, as we discussed, we need more data, and it's not feasible in all patient subgroups.
And what do you think about repeat revascularization as an outcome for these studies? I think it's not.
Yeah, it's always been a softer endpoint, and it's one of those things that
it's also a self-fulfilling prophecy.
It's a self-fulfilling prophecy, and this comes up with every time we debate on PCI versus CABG, and CABG reduces the repeat revascularization, and from patient perspective, I don't know which one. It's better to lay out all the options. That your point is very valid because the repeat revascularization is not in 100% of culprit-only revascularization. It's only on proportion of patients, a third of them at the max. So in other words, 2/3 of them, you're actually keeping them away from the cath lab. So I think it needs a full disclosure. So that's why if there is superiority only on repeat revascularization, I think the conversation is much different with the patient. Rather than a harder endpoint, I consider MI to be a hard endpoint too, and not necessarily mortality. Because if you look at now, we are waiting for the results of the complete trial. The complete trial is not going to be powered for mortality, so we're not going to see the difference in mortality.
It's death and MI.
It's death and MI, and we suspect that the results is going to be driven by MI rather than death.
So now, once you're done with ischemia and ischemia CKD, what is next?
Yeah, so there are many trials that are in the pipeline, are in the works. So one of them that I have been passionate about is to answer the question of how effective beta blockers are for stable coronary artery disease patients. In other words, we know that it can reduce angina, but beyond that, is there a role for beta blocker to reduce cardiovascular events in patients with stable coronary artery disease? So we are calling it the ischemia 2 trial, and so there is. So we are waiting to hear back from NHLBI. So there is interest, and we should hear more in January whether the trial will be fun.
And which beta blocker do you think?
Great question. So the trial design is going to be interesting because what we've seen is in this day and age, many patients, or most patients with stable coronary artery disease, are being placed on a beta blocker. So the design is if you're already on a beta blocker, there'll be a careful they'll be randomized either to continuing or discontinuing. So if you're discontinuing, it will be a carefully planned discontinuation, slow discontinuation. If you're continuing, we will recommend switch to a couple of beta blockers. A couple of beta blockers more to make sure that it's feasible worldwide. And we want to use newer beta blockers with more evidence. So we are advocating for carvedilol, bisoprolol, nebivolol. And if you're using metoprolol, the long extended release metoprolol.
That's great. So that would be a great trial to look forward to.
Yeah.
What about the field as such? What do you think is the future for ischemic heart disease?
So the field of ischemic heart disease is getting more interesting, and I think that's why it ties back because as you can see, there are more and more therapies, more and more efficacious therapies. But what we've been doing so far in the last 3 decades or so is we have had effective therapies back in the day, and then we add on medications. And there was, one of the recent articles looked at how many medications these patients are. On an average, many patients are on 10 different medications if you have stable coronary artery disease. The question is, when can we pull out some of the medication? So that's why this beta blocker trial is designed to deprescribe, take away older medications that were proven efficacious back in the day, but now you have more effective therapies, statins, reperfusion stuff. So I think, in addition to, getting more effective therapies longer term, we need a mechanism to say, oh, when can we actually take away medications proven back in the day, but maybe not as important these days. Because at the end of the day is medication compliance. If you have 10 medications on a patient, the compliance is going to be very poor. We need methods to actually maximize compliance, whether it's combination therapy or other means, because medications don't work if patients don't take them. So I think that's very critically important.
Right, great. So before we close, I just want to ask you one particular question about your thoughts on the inflammatory hypothesis.
Yeah.
Now that CANTOS has been published, so what is your take on that?
So it's interesting. I mean, the inflammatory hypothesis has been talked about for a couple of decades now, and it's only now with the CANTOS trial we see positive results. And of course, with the methotrexate trial being negative, so it's kind of a setback. But I must say that the CANTOS trial being what it is, I think has opened up more avenues. We need to test more. It's potentially that the difference in mechanism of action between methotrexate versus canakinumab may be driving this.
Methotrexate did not reduce.
It did not reduce TRP levels, and so I think there is a difference. So at least the field is open to target a novel pathway that we weren't routinely targeting in clinical practice. And of course, I mean, the medication is still not approved in the US, canakinumab. But I think that we'll see more and more trials targeting the inflammatory hypothesis. I know trials of using colchicine and stuff. So I think so far we've been targeting the lipid pathway, the thrombotic pathway, and I think this will be a very interesting avenue to test future medications.
Colchicine is a new canakinumab.
Yeah.
Anyway, great talking to you, Sripal.
Thank you. This is great. Thank you.